Hello and welcome back. If this is your first time here, you're in for an interesting night. Tonight we're talking about childbirth throughout history, and I promise you, it's nothing like what you'd expect. We're going back thousands of years to see how women actually did this before hospitals existed, before male doctors showed up with opinions, and before anyone decided that lying flat on your back was somehow the best position for pushing a human out of your body. Spoiler alert, it wasn't. Before we dive in, if you're enjoying these stories, hit subscribe, it really helps. And if you'd like to be gently acknowledged in a future video, drop a comment with your name and where you're listening from. We love knowing who's here from around the world, and we might give you a quiet thank you next time. Now get comfortable, adjust your pillow, pull up your blanket, and take in a deep breath. Tonight there's nowhere else you need to be, just here, listening to this strange, fascinating journey through time. In about an hour and a half, my voice will fade out and you'll hear gentle rain and a crackling fire to keep you company through the rest of the night. But for now, we're going on a trip through ancient Egypt, medieval Europe, Victorian hospitals, and everywhere in between. We'll see what worked, what didn't, and why some of the worst ideas in medical history happened to involve men who had never actually witnessed childbirth deciding they knew better than women who'd done it dozens of times. So settle in, let your mind relax, and let's begin this journey together. Let's start at the very beginning, which is tricky because nobody in the Paleolithic era was keeping detailed birth records. There were no instruction manuals, no hospitals, no birth plans typed up and laminated. Just women, other women, and the basic understanding that babies come out and someone needs to help. For tens of thousands of years, childbirth was handled by women who had done it before helping women who were doing it for the first time. Revolutionary concept, I know. Experience teaching the inexperienced. Knowledge passed down not through medical school, but through actual lived reality. And here's something interesting. For most of human history, women gave birth in positions that actually made sense. Squatting, kneeling, standing while holding on to something sturdy, sitting on a birth stool, leaning forward, basically anything except lying flat on your back with your feet in the air. Which, if you think about it for more than 3 seconds, makes absolutely no sense when you're trying to push something out of your body with the help of gravity. The flat on your back position is a relatively modern invention, and we'll get to exactly how that happened later. But for now, just know that for the vast majority of human existence, women instinctively knew that upright positions made birth easier. Because they do. Gravity helps. Your pelvis can open wider. The baby has a straighter path. It's not complicated. Midwives have existed for as long as humans have existed. The word itself comes from Old English, mid meaning with, and wife meaning woman. A woman who is with another woman. That's it. That's the job description. And for thousands of years that system worked pretty well. Not perfectly, obviously. Childbirth has always carried risks, but the risks were managed by people who actually knew what they were doing, who had seen dozens or hundreds of births, who understood what was normal and what wasn't, and who could make decisions based on experience rather than theory. Now let's talk about ancient Egypt, because the Egyptians were surprisingly practical about a lot of things, including birth. Egyptian women gave birth on special bricks called birth bricks. These weren't just any bricks. They were specifically made for childbirth, often decorated with images of gods and goddesses, particularly Taweret, the hippo goddess of childbirth. Yes, the Egyptians assigned a hippo to oversee birth, and honestly, if you've ever seen a hippo, you know they're incredibly protective and fierce. So it kind of makes sense. The woman would squat over these bricks, supported by other women. Sometimes there were 2 bricks, one under each foot, sometimes four, arranged so she could hold onto something while squatting. The exact setup varied, but the principle was the same. Upright position, gravity helping, experienced women surrounding her. Egyptian midwives were professionals. This wasn't a side job or something women did because they happened to be nearby. It was a recognized profession. Some midwives were even wealthy enough to have their own servants, which tells you something about how valued they were. They had pain management techniques too. Herbal remedies, massage, incantations that probably worked more through distraction and comfort than actual magic. But hey, if it helped, it helped. They understood that keeping a laboring woman calm and comfortable made the process easier. Groundbreaking stuff. Egyptian medical papyri, the ones that survived anyway, include information about pregnancy and childbirth. They had tests to determine if a woman was pregnant. Some of these tests were surprisingly accurate, based on observing changes in the body. Others were complete nonsense, like the one involving urinating on wheat and barley seeds to see which sprouted first to determine the baby's sex. But the point is, they were trying. They were observing, recording, learning. After birth, Egyptian women had a recovery period where they stayed in a special birthing pavilion for about 2 weeks. Other women brought them food, helped with the baby, let them rest. The community supported new mothers because they understood that recovery was necessary. Again, shockingly practical. Meanwhile, over in ancient Mesopotamia, childbirth was also managed by midwives and surrounded by rituals to protect both mother and baby. They called on various goddesses, burned incense, recited prayers. The actual medical care was less documented than Egypt's, but we know midwives were present and that childbirth was considered a communal female experience. Ancient Greece had a more complicated relationship with childbirth. Greek men, particularly philosophers and early physicians, liked to theorize about women's bodies without actually examining them or asking women about their experiences. Shocking. I know. Hippocrates, often called the father of medicine, wrote about pregnancy and childbirth. Some of his observations were accurate. Others were wildly wrong. He believed the womb wandered around the body causing problems, which is both hilarious and sad considering how long that idea persisted. But on the ground level, Greek women were still giving birth with the help of midwives. Midwives in ancient Greece were respected professionals, often older women who had given birth themselves. They knew anatomy, they knew what to do if something went wrong, and they knew how to support a woman through labor. Greek art sometimes depicted childbirth scenes, usually on pottery. These images show women in upright positions, supported by birth stools or other women. The birth stool was a common tool throughout the ancient world. It was basically a chair with a hole cut in the seat, allowing the woman to sit upright while the midwife could access the baby from below. Simple, practical, effective. Then we get to ancient Rome, where things got more superstitious, but the basic system remained the same. Roman women gave birth at home, attended by midwives and female relatives. Romans prayed to several goddesses during childbirth. Juno Lucina was the main one, goddess of childbirth and light, because babies were born into the light of life. Poetic, if you ignore the fact that most births probably happened in fairly dim rooms because bright light wasn't exactly readily available. There were also rituals to ensure an easy birth. All doors in the house had to be unlocked during labor, symbolically opening pathways for the baby. No one was allowed to cross their legs or fold their arms in the house because that would bind the birth. Knots had to be untied. Hair had to be loose. Anything that symbolized binding or closing had to be opened. Did any of this actually help? Medically, no. But psychologically, maybe. If everyone in the house was focused on the idea of opening, releasing, letting the baby come, that created an atmosphere of calm expectation rather than fear and tension. And we know now that fear and tension can actually slow labor, so perhaps all that superstition accidentally helped by keeping everyone's mindset positive. Roman midwives, called obstetresses, were trained professionals. Some were even literate and wrote medical texts, though most of those texts haven't survived. One midwife we know about is Salpi of Lemnos, who wrote about women's medicine and was referenced by later physicians. Another is Sotira, whose tombstone proudly declared she was a midwife, showing that it was a respected profession worth memorializing. Wealthy Roman women sometimes gave birth in elaborate birthing chairs, padded and comfortable, designed to support an upright position. Poorer women used simpler stools or just squatted on the floor with other women holding them up. But regardless of class, the principle was the same. Upright, supported, surrounded by experienced women. Romans also had some understanding of what could go wrong during birth. They knew about breech births and had techniques for trying to turn babies. They knew about hemorrhaging and had methods to try to stop bleeding, though their success rate wasn't great. They knew that sometimes babies died during birth, and sometimes mothers did too, and there wasn't always anything anyone could do about it. Life expectancy in ancient Rome was low, but it's worth noting that if you survived childhood, you had a decent chance of living into your 50s or 60s. The high mortality rate was largely driven by infant and child deaths. Maternal mortality during childbirth was certainly a risk, but it wasn't as catastrophically high as later periods would see, particularly once male physicians got involved. One thing that's important to understand about ancient childbirth is that it was a social experience. This wasn't a woman isolated in a hospital room with one nurse checking in every few hours. This was a woman surrounded by her mother, her sisters, her friends, her neighbors, the experienced women in her community who had all been through this before. That social support made an enormous difference. Labor can take hours or even days. Having people around who could encourage you, distract you, help you through contractions, bring you water, massage your back, that kind of continuous support is actually medically beneficial. Modern studies have shown that having a support person during labor, what we now call a doula, reduces the need for interventions and improves outcomes. Ancient women accidentally figured this out thousands of years ago simply by staying with each other through the process. Knowledge was passed down orally. A girl would grow up seeing the women in her family and community attend births. She'd learn what was normal, what to expect, what to do. By the time she gave birth herself, she'd already witnessed it multiple times. And by the time she was old enough to attend births as a helper, she had decades of observed experience. This system wasn't perfect. Ancient women didn't have modern medicine, antibiotics, blood transfusions, or cesarean sections. When things went seriously wrong, people died. But for normal, uncomplicated births, which are the vast majority, the ancient system of experienced midwives, upright positions, and community support worked remarkably well. So that's where we're starting. Thousands of years of women helping women, knowledge passed down through generations, birth treated as a normal life event rather than a medical emergency. Keep that in mind as we move forward in time, because you're going to see how dramatically things changed, and not always for the better. Next, we're heading into the medieval period, where the church got very interested in women's bodies, superstitions multiplied, and yet somehow women continued managing childbirth more or less the same way they always had. Because when you're actually in labor, theology doesn't matter nearly as much as having someone who knows what they're doing. In medieval Europe, everything was governed by the church, superstition was mixed with genuine medical knowledge, and women continued giving birth pretty much the same way they always had. Because fundamentally, bodies don't care what century it is. The medieval period gets a bad reputation, and some of it is deserved. Medicine was a mixture of ancient knowledge, religious belief, and completely made-up nonsense. But when it came to childbirth specifically, medieval women actually had a system that worked reasonably well, at least for the time. First, let's talk about who was in charge. Midwives. Still, always midwives. Men were not allowed in the birthing room. This wasn't optional. This was strict social custom backed by religious belief. Birth was women's business, and men had no place there. Even physicians, the few who existed, stayed out. If a male physician was consulted during a difficult birth, he would stand outside the door and shout instructions to the midwife inside. He wouldn't examine the woman. He wouldn't see anything. He'd just offer theoretical advice based on books he'd read, written by other men who also had never witnessed childbirth. Surprisingly, this system was not particularly effective. The birthing chamber was a sacred female space. When a woman went into labor, other women would arrive. Her mother, if she was still alive, her sisters, her neighbors, friends, the midwife. Sometimes a dozen women would crowd into the room, all there to support, encourage, and help. The room would be prepared specifically for birth. Curtains drawn, doors locked. This wasn't just for privacy. Medieval people believed that evil spirits and demons could harm a woman during childbirth, when she was vulnerable. So the room was sealed off, protected. Crosses were hung on the walls. Prayers were said. Protective charms were placed around the bed. Some of this was superstition. Some of it was practical. A dark, quiet room is actually conducive to labor. Bright lights and noise can slow contractions. Medieval women didn't know the medical reasons why, but they knew from experience that a calm, enclosed space helped. The midwife was usually an older woman who had given birth herself, multiple times. She'd been attending births for years, maybe decades. She knew what was normal. She knew what a healthy baby looked and sounded like. She knew how much bleeding was too much. She knew techniques to turn a breech baby, to slow a hemorrhage, to clear a baby's airway. Medieval midwives didn't have formal medical training in the way we think of it now, but they had something arguably more valuable. Experience. Lots and lots of experience. A midwife in a decent-sized village might attend 50 births a year. Over a 20 or 30-year career, that's hundreds of births. You learn a lot by doing something hundreds of times. And midwives shared knowledge. When a young woman was learning the trade, she'd apprentice with an experienced midwife, attending births, watching, learning. The older midwife would pass down everything she knew. This baby's head feels positioned wrong. Here's how you can tell. This amount of bleeding is normal. This amount is dangerous. This is how you massage the belly to help deliver the placenta. This is how you tie the cord. All of this knowledge was oral. Most midwives couldn't read or write, but oral tradition can preserve information remarkably well, especially when lives depend on it. Now, let's talk about the actual process of medieval birth, because it looked quite different from modern hospital birth. The woman was not lying flat on her back. We need to emphasize this because somehow, despite thousands of years of evidence that upright positions work better, modern medicine decided flat on your back was the way to go. We'll get to that disaster later. Medieval women gave birth on birth stools, which had been used since ancient times. These were low chairs with a curved seat that had a large opening in the middle. The woman would sit, sometimes with her back supported by another woman, and gravity would help bring the baby down. The midwife would kneel in front, ready to catch the baby. Some women preferred to kneel on cushions. Some stood, holding onto a rope suspended from the ceiling. Some leaned forward against a bed while other women supported them. The position varied based on what felt right to the woman, which is actually the correct approach. Bodies know what they need. Pain management in medieval times was limited but not non-existent. Midwives used herbal remedies. There are medieval texts that mention birthwort, mugwort, and other herbs being given to laboring women. Some of these herbs may have had mild, pain-relieving or muscle-relaxing properties. Some were probably useless, but the act of being given something, of being cared for, likely helped psychologically. Alcohol was sometimes used, a cup of strong wine or ale to help a woman relax. This wasn't ideal, obviously, but in terms of medieval pain management options, it wasn't the worst. Prayer was constant. Women would pray to Saint Margaret, the patron saint of childbirth. They'd pray to the Virgin Mary. They'd recite specific prayers that were believed to ease labor. There were even prayers written on strips of parchment that women would wear around their necks during labor, or place on their bellies, or even eat, because apparently consuming holy words was thought to help. Did any of this actually work? Medically, probably not. But the psychological comfort of faith, of feeling protected and supported by divine power, may have helped women stay calm. And staying calm genuinely does help labor progress. Now here's where things get complicated. The medieval church had very specific opinions about childbirth pain. According to church doctrine, labor pain was Eve's punishment for the sin in the Garden of Eden. Genesis 3:16, God tells Eve, "In pain you shall bring forth children." Therefore, pain in childbirth was theologically necessary. It was divine punishment, and you weren't supposed to try to escape it. This meant the church was officially against pain relief. Suffering during childbirth was spiritually appropriate. Some theologians argued that trying to reduce labor pain was going against God's will. In practice, this didn't stop midwives from trying to help women. They'd use their herbs, their massage techniques, their comfort measures, but they had to be careful not to be too obvious about it, because if the local priest decided a midwife was using forbidden methods, that midwife could be accused of witchcraft. And yes, we need to talk about the witch hunts, because they had a significant impact on midwives. During the late medieval period and into the early modern period, Europe went through waves of witch hysteria. Tens of thousands of people, mostly women, were accused of witchcraft and executed, and midwives were particularly vulnerable to these accusations. Why? Because midwives dealt with life and death. They had knowledge of herbs and remedies. They performed rituals and spoke incantations. They had power in the birthing room. And in a society that was increasingly suspicious of women with knowledge and power, that made them targets. If a baby died during birth, the midwife might be accused of causing it through witchcraft. If a baby was born with a deformity, same accusation. If a woman died in childbirth, the midwife could be blamed. Never mind that infant and maternal mortality happened for medical reasons. Superstition and fear needed someone to blame. Some midwives were required to swear oaths before church authorities, promising they wouldn't use magic or harmful practices. They had to operate under constant suspicion, even though they were providing essential community service. This climate of fear affected how midwives worked. They had to be careful about what remedies they used, what they said, how they acted. Knowledge that might have been shared openly became whispered, hidden, passed along secretly. The witch hunts didn't just kill individuals. They damaged the entire system of women's medical knowledge. Despite all this, medieval women continued to give birth, and most of them survived. Maternal mortality was certainly higher than today, but it wasn't the catastrophic bloodbath that people sometimes imagine. Most births were normal. Most babies were born healthy. Most mothers recovered. The biggest killers weren't lack of medical intervention. They were poverty, malnutrition, disease, and infection. A malnourished woman is at higher risk during childbirth. A woman weakened by recurring illness is more vulnerable. A woman living in unsanitary conditions is more likely to develop an infection after birth. Wealthy medieval women had better outcomes than poor ones. Not because they had better medical care, they had the same midwives, but because they were better fed, lived in cleaner conditions, and could afford a longer recovery period. After birth, medieval women had a lying-in period. This was typically about a month where the new mother stayed in bed or close to it, recovering, bonding with the baby, being cared for by other women. She didn't do household work. She didn't cook or clean. She rested. For wealthy women, this lying-in period was elaborate. They'd stay in a specially prepared chamber, hung with expensive fabrics, visited by friends bringing gifts. It was a social event as much as a recovery period. For poor women, the lying-in period was shorter and less comfortable, but it still existed. The community understood that new mothers needed rest. Neighbors would bring food, help with older children, take over chores. This postpartum support was crucial. Modern medicine has discovered that postpartum care and rest significantly affect maternal health and reduce complications. Medieval women knew this instinctively. There was also a religious ceremony called churching that happened after the lying-in period. The new mother would go to church to be blessed and welcomed back into the community. This ceremony has been interpreted different ways by historians. Some see it as treating women as unclean after birth, needing purification. Others see it as a celebration, a way to mark the end of a dangerous period and the mother's survival. Probably it was both. Medieval people were comfortable with contradictions. One thing that's important to understand about medieval childbirth is that it was expected. Women knew they would likely give birth multiple times in their lives. Families were large, partly because infant mortality was high, and partly because there was no reliable birth control. A woman might go through 10 pregnancies, maybe more. Some babies would die in infancy. Some mothers died during one of these births, but many women survived all their pregnancies and lived to be grandmothers who attended their own daughters' births, passing down knowledge to the next generation. The medieval approach to childbirth was far from perfect. The superstition, the religious guilt about pain, the witch hunts that threatened midwives, these were all problems. But the core system, women helping women, experienced midwives, attending births, upright positions, community support, that core system worked. And then men decided they wanted to be involved. That's where our story takes a turn. Because the 1600s and 1700s are when male physicians decided that childbirth was a medical event that required their expertise, despite the fact that they had no experience and a lot of very bad ideas. But before we get to that disaster, take a moment to appreciate what we've covered. From ancient Egypt to medieval Europe, thousands of years of women managing childbirth successfully. Not perfectly, people died, medicine was limited, but successfully enough that humanity continued and knowledge was preserved. The system worked because it was based on experience. Women who had given birth helped women who were giving birth. Knowledge was shared. Techniques were refined over generations. Positions and practices that worked were kept. Ones that didn't were discarded. It was practical, communal, and woman-centered. Remember that, because in the next part, we're going to see what happened when men with theories but no experience took over. Spoiler alert, it wasn't great. Alright, we've reached the period where everything starts going sideways. For thousands of years, childbirth was managed by women who knew what they were doing. And then, in the 1600s and 1700s, male physicians decided they should be involved. The problem? They had never attended a birth. They had never seen a vagina in a medical context. They had read books written by other men who also had never attended births. But they had confidence. So much confidence. Let's start with how this even happened. In most of Europe, midwifery was still women's domain, but things were changing. Medicine was becoming more formalized, more scientific, or at least it was pretending to be. Universities were training physicians, and these university-trained men started looking at midwifery and thinking, we could do that. We should do that. Never mind that midwives had centuries of practical experience. Never mind that they actually knew what they were doing. These male physicians had theories. They had read Hippocrates and Galen. They had studied anatomy on cadavers. Surely that was better than mere experience. The first male physicians who got involved in childbirth were called man midwives or accoucheurs. The term itself tells you something. They needed a special name because their presence was unusual and somewhat scandalous. Initially, man midwives were only called for complicated births. If something was going seriously wrong, if the baby was stuck, if the mother was dying, then maybe a male physician would be summoned. He'd bring his tools, his forceps, his knowledge from books, and he'd try to help. Sometimes it worked. Sometimes the baby was saved. Sometimes the mother survived. But often, by the time a male physician was called, it was already too late. The situation was desperate, so male physicians became associated with death and disaster, which honestly was pretty accurate. But here's where things get interesting. Wealthy women started requesting male physicians for normal births. Not because male physicians were better, they weren't, but because having a male physician attend your birth was a status symbol. It showed you could afford the newest, most expensive medical care. It was fashionable. This is important to understand. The shift from midwives to physicians wasn't driven by medical outcomes. It was driven by social status and fashion. Rich women wanted what was new and exclusive. Male physicians were new and exclusive. Therefore, rich women wanted male physicians. Poor women, who couldn't afford physicians, continued using midwives. And here's the kicker: they had better outcomes. Now let's talk about the biggest innovation male physicians brought to childbirth, the thing that defined their involvement and justified their presence: forceps. Forceps are metal instruments that look like large tongs or salad servers. They're designed to go around a baby's head and pull the baby out. When used correctly by someone who knows what they're doing, they can save lives. When used incorrectly, they can crush a baby's skull or tear a mother's body apart. The Chamberlain family in England invented forceps in the late 1500s and kept them secret for over a century. Secret. They would attend difficult births, demand huge fees, blindfold the laboring woman so she couldn't see what they were doing, and use their mysterious instrument to deliver babies. This was their business model. Keep the tools secret, charge enormous amounts, build a reputation as miracle workers, and to be fair, forceps could sometimes deliver a baby that was stuck, so they did save some lives. But the secrecy meant other physicians couldn't learn, couldn't improve the design, couldn't develop better techniques. Eventually, the secret got out. By the early 1700s, forceps were becoming known throughout Europe. Male physicians rushed to use them, because finally, here was something they could do that midwives couldn't. Midwives didn't have forceps. Midwives weren't allowed to use forceps. Forceps were restricted to trained physicians, which meant men. This gave male physicians a genuine advantage in difficult births. If a baby was truly stuck, forceps might be the only option. So gradually, male physicians became seen as necessary for difficult cases. Then for any case that might become difficult, which is a very convenient expansion of their market. But here's what else male physicians brought to childbirth: the lithotomy position, lying flat on your back with your legs up in stirrups. Why did they want women in this position? Not because it helps the woman. It doesn't. It makes birth harder. Gravity works against you. Your pelvis can't open as wide. The baby has to travel uphill. It's a terrible position for giving birth, but it's a great position for the physician. He can see everything. He can access everything. He can sit comfortably on a chair while he works. The flat position was designed for the convenience of the physician, not the comfort or safety of the mother. Midwives had always let women choose their position. Stand, squat, kneel, whatever felt right. But male physicians wanted control. They wanted women in a position where the physician had the best view and access. So the lithotomy position became standard in physician-attended births. Women were told this was better, more modern, more scientific. In reality, it made birth more difficult and more dangerous, but it looked professional, and that mattered more. The other thing male physicians brought was modesty concerns that bordered on absurd. A male physician examining a woman's private parts was scandalous, so they developed workarounds that were somehow even more ridiculous. Many male physicians would examine women under a sheet. They'd put their hands under the fabric and examine by touch, alone, without looking. They'd deliver babies in dimly lit rooms, under blankets, with as little visibility as possible. Think about this. They insisted on being present for birth. They claimed their expertise was essential, but they refused to actually look at what they were doing because that would be immodest. Midwives had no such problem. Women examining women wasn't scandalous. Midwives could see what they were doing. They could make accurate assessments. They could spot problems early. Male physicians, working blind under blankets, had to guess, and their guesses were often wrong. There's a famous story about a physician who delivered what he thought was a baby but turned out to be a tumor. He had been feeling around under a sheet, felt something coming out, and assumed it was a head. It wasn't. If he had just looked, he would have known immediately. But modesty was more important than accuracy, apparently. Meanwhile, in France, something slightly better was happening. French midwifery was becoming more formalized and professionalized. The Hôtel Dieu in Paris trained midwives in a more systematic way. They learned anatomy, they studied complications, they developed techniques. French midwives were respected professionals. Some wrote textbooks. Angélique de Coudray was a famous French midwife who traveled throughout France in the 1700s, teaching peasant women proper midwifery techniques. She used a life-sized mannequin made of fabric and stuffing to demonstrate deliveries. She trained thousands of midwives over her career. France was ahead of the curve in recognizing that midwives needed formal education, but that didn't mean replacing them with male physicians. It meant making them better at what they already did. England and the American colonies went a different direction. They started pushing midwives out in favor of male physicians, and the outcomes got worse. Let's talk about puerperal fever, also called childbed fever. This is an infection that develops after childbirth, usually in the uterus. Before antibiotics, it was often fatal. Women would give birth, seem fine, then a few days later develop a fever, become delirious, and die within a week. Puerperal fever had always existed, but it became an epidemic in the 1700s and 1800s, particularly in hospitals. Women who gave birth in hospitals started dying at alarming rates. Sometimes entire maternity wards would be wiped out, one woman after another, dying of the same infection. Nobody understood why. Germ theory didn't exist yet. Nobody knew about bacteria. They came up with all sorts of theories: bad air, miasma, divine punishment, moral weakness. Here's what was actually happening. Male physicians were going from autopsies directly to deliveries without washing their hands. They'd spend the morning dissecting corpses, learning anatomy, then walk into the maternity ward and examine laboring women with the same unwashed hands. They were literally transferring death from corpses to living women, and they had no idea. Midwives, who attended home births, didn't have this problem. They weren't doing autopsies. They were going from one home to another, and while they weren't washing with antibacterial soap, they also weren't handling dead bodies right before catching babies. So women who gave birth at home with midwives had much lower rates of childbed fever than women who gave birth in hospitals with physicians. But nobody made that connection yet. One man did figure it out. Ignaz Semmelweis, a Hungarian physician working in Vienna in the 1842. He noticed that the maternity ward staffed by physicians had a much higher death rate than the ward staffed by midwives. He started investigating why. He eventually concluded that physicians were carrying something deadly on their hands from the autopsy room to the delivery room. He implemented a strict hand-washing policy using chlorinated lime solution. The death rate plummeted immediately. Semmelweis had proven that hand-washing saved lives. He had data, he had evidence, he published his findings, and the medical establishment destroyed him. Other physicians were insulted by the suggestion that they were causing deaths. The idea that gentlemen physicians could be carrying disease was offensive. They refused to wash their hands. They mocked Semmelweis. They ostracized him professionally. Semmelweis became increasingly frustrated and angry. He started writing open letters, attacking physicians who wouldn't wash their hands, calling them murderers. His behavior became erratic. Eventually, he was committed to a mental institution, where he died 2 weeks later at age 47, possibly beaten by guards. The medical community ignored his findings for decades. Women continued dying of childbed fever because physicians refused to wash their hands, all because acknowledging that hand-washing helped would mean admitting they had been wrong. Meanwhile, midwives continued attending home births, and their patients continued having lower infection rates. But nobody wanted to admit that maybe, just maybe, the traditional system had been working better. By the late 1700s, the pattern was set. Wealthy women used male physicians and gave birth lying flat on their backs. Poor women used midwives and gave birth in more natural positions. The wealthy women had higher rates of complications and infections. The poor women had better outcomes, but status mattered more than outcomes, and male physicians were winning the PR battle. They had education, they had university credentials, they had forceps and other tools. They looked scientific and modern. Midwives had centuries of experience and better results, but experience wasn't valued anymore. Credentials were valued, theory was valued, tools were valued. Practical knowledge from women was dismissed as old-fashioned superstition. Theoretical knowledge from men who had read books was praised as modern science. And childbirth, which had been relatively safe when managed by experienced women, was becoming more dangerous as it was taken over by confident men who didn't know what they were doing. The 1800s would make all of this even worse. Hospitals would become death traps. Interventions would multiply, and maternal mortality would reach levels that hadn't been seen since the plague. But we'll get to that disaster next. For now, just understand this shift that happened in the 1600s and 1700s. Childbirth went from being a normal life event managed by experienced women to being a medical procedure managed by physicians with tools. It looked more impressive. It sounded more scientific. And it killed more women. Progress. Welcome to the 1800s. where childbirth reached peak absurdity and danger. This is the century where birth moved into hospitals, and women started dying at rates that would have shocked medieval midwives. This is when medical intervention became standard and outcomes got catastrophically worse. This is the Victorian era, and it was a disaster. Let's set the scene. The Industrial Revolution was in full swing. Cities were growing, hospitals were being built, and medicine was becoming increasingly confident in its ability to improve on nature, despite all evidence to the contrary. The wealthy still gave birth at home, but now with physicians in attendance almost exclusively, the middle class aspired to the same, and the poor, who had always given birth at home because they had no choice, were now being encouraged to give birth in charity hospitals. These charity hospitals were presented as modern, clean, scientific alternatives to dirty home births. In reality, they were death traps. Hospital wards in the 1800s were overcrowded, understaffed, and filthy by modern standards. Multiple women would labor in the same room, sometimes in beds just feet apart. The same doctors and medical students would examine woman after woman without washing their hands between patients. Remember puerperal fever, that infection we talked about? It was rampant in hospitals. Entire maternity wards would be wiped out by waves of infection. A woman would come in healthy, give birth, and then die within days. Not occasionally, regularly. In some hospitals, the maternal mortality rate reached 20% or higher. 1 in 5 women who gave birth in a hospital died. Those are wartime casualty numbers, and this was supposed to be progress. Meanwhile, women giving birth at home with midwives had mortality rates around 2 to 3%, significantly lower. But the medical establishment insisted hospitals were safer because they looked more official and had more equipment. The equipment itself was often the problem. Forceps, which could be life-saving when used correctly, were being overused and misused. Medical students would practice on laboring women. Young doctors would use forceps on births that didn't need them, just to get experience. Women were treated as teaching material, and because this was the Victorian era, nobody asked the women how they felt about this. Women's opinions on their own medical care were considered irrelevant. The doctor knew best, always. Even when the doctor was a 2-3-year-old who had read about childbirth in a textbook but never actually witnessed it. Let's talk about Dr. James Marion Sims, who is often called the father of modern gynecology. He developed surgical techniques to repair fistulas, which are holes that can develop between the vagina and bladder or rectum after traumatic childbirth. These fistulas caused constant leaking and were extremely debilitating. Sims' technique helped many women. He operated on the same women multiple times, refining his technique through trial and error on their bodies. When he later operated on white women, he used anesthesia. But the enslaved women he experimented on received none. Even though anesthesia was available, Sims believed black women didn't feel pain the same way white women did, which was racist pseudoscience but convenient for his research. This is the foundation of modern gynecology, built on the bodies of enslaved women who had no choice and no voice. Victorian medicine was shot through with racism, classism, and misogyny. Poor women and women of color were used as test subjects. Their pain was dismissed. Their experiences were ignored. And when treatments were developed on their bodies, those treatments were then marketed to wealthy white women as modern scientific advances. Now let's talk about anesthesia, because it's a complicated story. Ether and chloroform were discovered in the 1,840 seconds. Suddenly, surgery could be done without the patient being conscious and in agony. This was revolutionary. Amputations, tumor removals, all sorts of procedures became more bearable. Could anesthesia be used for childbirth? Technically, yes. But there was immediate controversy. Remember, The church had spent centuries teaching that labor pain was Eve's punishment and therefore necessary. Many physicians and clergy argued that removing pain from childbirth was going against God's will. Women were supposed to suffer. It was spiritually important. Some physicians also argued that labor pain served a purpose. They believed pain helped the mother bond with the baby. Pain made you appreciate motherhood more. Pain was character building. These were men, by the way. Men who would never experience labor, telling women that feeling their organs tear apart was good for them. But in 1853, Queen Victoria used chloroform during the birth of her 8th child. She had it administered by a physician named John Snow, who carefully monitored the dose. She called it that blessed chloroform, and used it again for her 9th child. The Queen of England had publicly endorsed pain relief during childbirth. Suddenly, it was fashionable. The religious objections didn't disappear, but they got quieter. Chloroform and ether became available for wealthy women who could afford a physician skilled in administering them. Poor women, as always, got nothing. But even for wealthy women, anesthesia was risky. Some women died from the anesthesia itself. Others died because the anesthesia was given improperly and they inhaled vomit while unconscious. Still, many women wanted it. Labor hurts. If there was something that could reduce the pain, women wanted access to it. The fact that men had spent centuries telling women they deserved to suffer made the availability of pain relief feel like defiance. Then came twilight sleep, and things got even stranger. In the early 1900s, a combination of morphine and scopolamine became popular. This wasn't quite anesthesia. You weren't completely unconscious, but you wouldn't remember anything afterward. You'd go through labor, give birth, and have zero memory of it. This was marketed to women as the perfect solution. No pain, no memory, no trauma. You'd go to sleep pregnant and wake up with a baby. Sounds great. In practice, it was horrifying. Women under twilight sleep would thrash, scream, fight. They had to be restrained. Some hospitals put women in padded cribs with high bars so they couldn't hurt themselves. They'd tie women's hands, put them in straitjackets. The women weren't actually peaceful or pain-free. They were experiencing everything but wouldn't remember it later. The scopolamine caused amnesia, not pain relief. So women would go through hours of agony, fighting against restraints, and then wake up with no memory and be told they'd had a nice, peaceful birth. The staff knew what was really happening. But as long as the woman didn't remember, it was considered a success. Twilight sleep became hugely popular in the 1,910 seconds and 1,920 seconds, particularly in America. Women's magazines promoted it. Some women even went to Germany specifically to give birth under twilight sleep because German hospitals were known for offering it. But gradually, people realized this wasn't actually better. Women who had supposedly peaceful births were waking up with traumatic injuries they couldn't explain. Babies born to mothers under twilight sleep were often sluggish, drugged through the placenta. Some babies died. Some women died. By the 1,930 seconds, twilight sleep was falling out of favor, but it had done damage. It had established the idea that birth should be something women were unconscious for. That awareness during birth was a problem to be solved rather than a natural part of the experience. Meanwhile, through all of this, hospitals were developing increasingly interventionist approaches to birth. The more technology they had, the more they used it. Episiotomies became routine. This is a cut made in the perineum to enlarge the vaginal opening during birth. Sometimes episiotomies are necessary to prevent severe tearing, but in the early to mid-1900s, they became standard practice. Every woman got one, whether she needed it or not. The reasoning was that a clean surgical cut would heal better than a natural tear. This seemed logical. It was wrong. Research later showed that routine episiotomies actually cause more problems than they prevent. Natural tearing, when it happens, is usually minor and heals well. Surgical cuts are often more severe and take longer to heal. But for decades, routine episiotomy was standard care. Every woman who gave birth in a hospital got cut because doctors believed surgical intervention was better than natural processes. Shaving became routine. Before labor, women would have all their pubic hair shaved off. The reasoning was cleanliness, preventing infection. The reality was that shaving causes tiny cuts in the skin, and those cuts can be entry points for infection. So routine shaving probably increased infection risk rather than decreasing it. But it looked clean and medical, so hospitals kept doing it. Enemas became routine. Before labor, women would be given enemas to empty their bowels. The reasoning was that an empty bowel gave the baby more room and prevented contamination during birth. In practice, enemas are uncomfortable, sometimes cause dehydration, and don't significantly affect birth outcomes. But they became standard because someone decided they should be. All of these interventions, shaving, enemas, episiotomies, lying flat, being in a hospital at all, they weren't based on evidence. They were based on the idea that medical intervention was inherently better than natural processes. Doctors knew best. Women's bodies needed to be managed and controlled, and fathers still banned. In most hospitals, through the 1,950 seconds, fathers were not allowed in delivery rooms. They'd pace in waiting rooms while their wives gave birth alone with strangers. The moment of their child's birth was something they'd hear about secondhand. This wasn't for medical reasons. It was because hospitals decided that birth was too messy and emotional for men to witness. Better to keep them separate. Never mind that for thousands of years, birth had been a communal event with family present. Hospitals had rules. Birth happened according to hospital schedules, hospital protocols, hospital convenience. The woman giving birth had less control than she would have had at home. And yet, women kept going to hospitals because hospitals represented modernity, science, safety. Even though the statistics showed home births with midwives were safer, the cultural message was clear. Hospitals were progress, home birth was backward. By the mid-1900s in America, over 90% of births happened in hospitals. Midwifery was nearly extinct. In some states, it was illegal. Women had to give birth in hospitals attended by physicians because that was the only legal option. The transition was complete. Birth had been fully medicalized. It was no longer a natural life event. It was a medical procedure requiring professional intervention. And maternal mortality? In the early 1900s, it was actually higher than it had been in previous centuries. All this modern medicine, all these interventions, and women were dying at rates that would have shocked medieval midwives. It wasn't until the 1,940 seconds, with the introduction of antibiotics and blood transfusions, that maternal mortality started dropping significantly. Those two things, antibiotics to fight infection and blood transfusions for hemorrhage, saved countless lives. But notice what actually made the difference. Not the interventions, not the routines, not the control. Medicine that fought infection and blood loss. The basics. Everything else. The stirrups and the shaving and the episiotomies and the twilight sleep. That was theater. It made birth look medical and controlled, but it didn't make birth safer. Often, it made it more dangerous. The Victorian era and early 1900s represent the peak of medical arrogance around childbirth. Physicians were absolutely certain they knew better than thousands of years of women's experience. They were wrong. But they had power, and they used it. Women had no choice. You gave birth how the hospital said you'd give birth. Your preferences didn't matter. Your comfort didn't matter. The hospital protocol mattered. It would take another few decades and a lot of angry women before that started to change. But we'll get to that revolution next. For now, just sit with how strange this period was. Birth moved into hospitals and became more dangerous. Interventions multiplied and outcomes got worse. Women lost control of their own bodies, and everyone called it progress. The 1800s and early 1900s were a low point for childbirth. We haven't fully recovered yet. By the 1950 seconds and 60 seconds, birth in America and much of Europe had become a standardized medical procedure. You went to the hospital. You labored alone or with nurses. You were given drugs. You were put in stirrups. The doctor delivered your baby. You woke up in recovery. That was birth, and some women started asking, why? The natural childbirth movement began as a reaction to this over-medicalization. Women who had experienced hospital births started questioning whether all these interventions were necessary, whether birth had to be this way. One of the pioneers was Grantley Dick Reed, a British obstetrician who published Childbirth Without Fear in 1942. His core idea was that fear causes tension, tension causes pain, and if you could eliminate fear, you could reduce pain. He advocated for education, relaxation techniques, and minimal intervention. Dick Reed's ideas were controversial. Many physicians dismissed him. Pain-free childbirth without drugs? Impossible. Women needed medical management. They couldn't be trusted to birth on their own. But some women read his book and thought, that makes sense. They wanted to try. They wanted less intervention, more control, more awareness during birth. Then came Fernand Lamaze, a French obstetrician who developed the Lamaze method in the 1950 seconds. Lamaze borrowed techniques from Russian research on conditioned responses. The idea was that women could be trained to respond to contractions with specific breathing patterns and relaxation techniques rather than with tension and panic. Lamaze classes became popular. Couples would attend together. They'd learn breathing patterns. Hee-hee-hoo. They'd practice relaxation. The partner would learn how to support the laboring woman, how to time contractions, how to help. This was revolutionary for one specific reason. Partners were being included. For the first time in decades, fathers were being invited back into the birth process. Not just to pace in waiting rooms, but to be actively involved, to support, to witness their child's birth. Hospitals resisted. Birth was medical. Partners would be in the way. They might faint. They might get emotional. Better to keep them out. But women pushed back. If I'm going through labor, I want my partner there. I want support. I want someone I trust. Not just hospital staff I've never met. Gradually, hospitals started allowing partners in labor rooms, then in delivery rooms. By the 1970 seconds, it was becoming standard. The father could be present for his child's birth. What a concept. The other major figure in the natural birth movement was Ina May Gaskin, an American midwife who founded a commune in Tennessee called The Farm in the 1970 seconds. Gaskin and her team of midwives attended home births and kept meticulous records. Their outcomes were remarkable. Low intervention rates, low cesarean rates, low infant mortality, low maternal mortality, better than many hospitals. and they published their data. Gaskin's books, particularly Spiritual Midwifery and later Ina May's Guide to Childbirth, became essential reading for women interested in natural birth. She advocated for upright positions, freedom of movement during labor, minimal intervention, trusting the body's ability to give birth. These weren't new ideas. This was how birth had been managed for thousands of years. But in the 1,970 seconds, they were considered radical. The natural birth movement wasn't anti-medicine, it was anti-unnecessary intervention. The argument was simple. Most births are normal. Normal births don't need extensive medical intervention. Save the interventions for when they're actually needed. But the medical establishment had spent decades building a system based on routine intervention. Hospitals had protocols. Physicians had been trained a certain way. Changing the system was like turning a cruise ship. Slow, difficult, resisted. Some hospitals started offering more options. Birthing rooms that looked less clinical, more homey. Allowing women to walk during labor instead of being confined to bed. Delaying routine interventions unless there was a clear medical reason. But progress was uneven. Some hospitals embraced change. Others dug in. And physicians varied wildly. Some were open to patient preferences. Others insisted their way was the only safe way. Meanwhile, cesarean rates started climbing. A cesarean section is surgical delivery through an incision in the abdomen and uterus. It's major surgery. It's life-saving when necessary, but it comes with risks. Higher infection rates, longer recovery, potential complications in future pregnancies. In the 1,960 seconds, the cesarean rate in the US was around 5%. By the 1,980 seconds, it had climbed to over 20%. By the 2000s, over 30%. Today, it's around 32%. Why? Multiple factors. Better surgical techniques made cesareans safer, so they were used more readily. Fetal monitoring became standard, and doctors would see something concerning on the monitor and decide to do a cesarean. Malpractice concerns made physicians more intervention-prone. If anything went wrong during a vaginal birth, the doctor could be sued. A cesarean looked more defensible. The phrase, once a cesarean, always a cesarean, became standard practice. If you'd had one cesarean, future births would also be cesareans. This was based on concerns about uterine rupture during labor. Those concerns were somewhat valid, but the blanket policy meant that once you'd had one surgical birth, all future births would be surgical too. Women started pushing back against this. VBAC, vaginal birth after cesarean, became a movement. Women who'd had cesareans wanted the option to try vaginal birth next time. Some hospitals allowed it, others banned it. The medical community was divided. Through all of this, home birth midwifery was experiencing a quiet resurgence. Some women, frustrated with hospital protocols and lack of control, chose to give birth at home with trained midwives. This was controversial. The medical establishment called it dangerous, irresponsible. They pointed to rare cases where home births went wrong and women or babies died. They ignored data showing that for low-risk pregnancies, planned home births with trained midwives had outcomes comparable to hospital births. The debate became polarized. Hospitals insisted they were the only safe option. Home birth advocates insisted hospitals were too interventionist. Both sides had valid points. Both sides also had extremists who made reasonable discussion difficult. What was clear from the data was that the US had worse maternal and infant mortality rates than many developed countries, despite having one of the most medicalized, intervention-heavy birth systems. Countries like the Netherlands, where home birth with midwives was common and respected, had better outcomes. This suggested that maybe, just maybe, more intervention wasn't always better. Maybe the US system had overcorrected. Maybe birth had become too medicalized. But changing systems is hard. Hospitals had invested in expensive equipment. Physicians had trained for years in interventionist approaches. Insurance companies had built payment structures around medical procedures. There was enormous institutional inertia, and then there's the racial disparity we need to talk about. Because Black women in America die during childbirth at 3 to 4 times the rate of white women, this gap persists regardless of income or education. Wealthy, educated Black women still face higher risks than poor white women. Why? Racism in medical care. Black women's pain and concerns are taken less seriously. They're more likely to have their symptoms dismissed. They're less likely to receive adequate pain management. They face implicit bias from healthcare providers who make assumptions based on race. Serena Williams, one of the greatest athletes in the world, nearly died after giving birth because medical staff initially dismissed her concerns about a pulmonary embolism. She knew her body. She knew something was wrong. She specifically told them what she thought was happening, and they didn't listen. If Serena Williams, wealthy and famous, couldn't get adequate care, what chance do other Black women have? This isn't a historical problem. This is happening now. Black women are still dying at rates that are completely unacceptable. And it's not because they don't have access to hospitals. It's because the medical system treats them differently. Indigenous women face similar disparities. Latina women face disparities. The American maternal mortality rate is shameful for a wealthy country. And it's even more shameful when you break it down by race. Meanwhile, other countries had figured out better systems. The Netherlands, as mentioned, had integrated midwifery. Low-risk women could choose home birth with a midwife or hospital birth with a midwife. High-risk women went to hospitals with obstetricians. The system was flexible, responsive to individual needs, and had excellent outcomes. Scandinavian countries invested in long maternity leaves, home visiting nurses, comprehensive prenatal care. Their maternal and infant mortality rates were among the lowest in the world. The UK had the NHS, which, despite its problems, provided universal prenatal care and offered both midwife-led and physician-led birth options. These countries proved that you didn't need maximum intervention to achieve good outcomes. You needed good prenatal care, trained attendants, respect for the birthing person's choices, and interventions available when actually necessary. The US had the interventions but often lacked the other pieces. Prenatal care was expensive and inconsistent. Many women couldn't afford regular checkups. Maternity leave was minimal or non-existent, and respect for patient choice was hit or miss depending on your hospital and physician. By the 1992s and 2000s, some American hospitals were trying to do better. They created midwifery programs. They offered labor support through doulas. They reduced routine interventions. They allowed more movement during labor, more position choices, more partner involvement. But change was slow and inconsistent. The culture of American obstetrics remained heavily interventionist. Students were trained that way. Attending physicians practiced that way. Changing culture takes generations. One positive development was the evidence-based medicine movement. Researchers started actually studying birth practices. What works, what doesn't, what interventions improve outcomes, which ones are just tradition. Some findings were surprising. Continuous fetal monitoring, which had become routine, didn't actually improve outcomes for low-risk births. It just led to more cesareans without reducing infant mortality or injury. Routine episiotomy didn't improve outcomes. It increased complications. Restricting food and drink during labor didn't improve outcomes. It just made laboring women uncomfortable and depleted. Lying flat on your back was still the worst position for pushing, thousands of years later. As evidence accumulated, some practices changed. Routine episiotomy declined. Some hospitals stopped requiring continuous monitoring for low-risk patients. Some allowed women to eat lightly during labor. But other practices persisted despite evidence, because tradition is powerful and change is hard. The rise of the internet helped women access information. They could research their options. They could connect with other women, share experiences, learn about alternatives. Information that used to be available only through physicians was now accessible to anyone with a computer. This made some physicians uncomfortable. Patients coming in with research, with questions, with opinions about their own care. That's not how it used to work. Patients were supposed to trust the doctor, follow the doctor's advice, not question. But many women weren't willing to be passive patients anymore. This is my body. This is my baby. I have the right to understand my options and make informed decisions. The concept of informed consent became more prominent. You can't just do procedures to people without explaining what you're doing and why and getting their agreement. Patients have rights. This sounds obvious now, but it was a significant shift in medical culture, especially in obstetrics, where paternalism had been the norm for so long. By the 2010 seconds, the birth landscape in America was diverse. Most women still gave birth in hospitals, but their experiences varied wildly. Some had highly medicalized births with every intervention available. Some had minimal intervention births with midwives. Some had cesareans. Some had VBACs. Some transferred from planned home births to hospitals. There was no single right way anymore. Women had options, though access to those options depended heavily on geography, insurance, and hospital policies. The rise of birth photography and videography allowed women to document and share their experiences. Birth went from being hidden and private to being posted on social media. This normalization helped, showing the reality and diversity of birth experiences. The COVID-19 pandemic in 2020 created new challenges. Hospitals restricted visitors. Partners were sometimes banned again, bringing back the isolation of earlier eras. Some women chose home birth to avoid hospital restrictions. The pandemic highlighted how quickly birth policies could change and how little control individuals had. As we move further into the 2020 seconds, conversations about birth continue evolving. There's more awareness of racial disparities, more attention to patient rights and informed consent, more research on what actually improves outcomes, but we're still dealing with the legacy of 200 years of over-medicalization. We're still unwinding assumptions and protocols that were established for physician convenience, not patient benefit. Progress has been made. Women have more choices now than they did in the 1,950 seconds. Partners can be present. Natural birth is an option. Home birth is legal in most places, though not always accessible. But we're not where we should be. Maternal mortality in the US is still too high, and too many women still don't feel heard, respected, or in control during their births. The journey continues. We've spent most of this journey focused on Europe and America, but birth has been happening everywhere, in every culture, throughout all of human history, and the approaches have been remarkably diverse. Let's take a wider view, because the Western medical model of birth is not universal, and it's not necessarily the best. In many parts of Africa, traditional birth attendants still serve their communities. These are women, usually older, who have attended hundreds of births. They use techniques passed down through generations. They know herbal remedies, massage, positioning, all the practical knowledge that comes from experience. Some countries have tried to integrate traditional birth attendants into the formal healthcare system, providing them with basic medical training, clean delivery kits, and connections to hospitals for emergencies. When this integration is done respectfully, acknowledging their expertise while adding modern medical knowledge, outcomes improve. Other countries have tried to eliminate traditional birth attendants, insisting all births must happen in facilities with trained medical staff. The problem? Many communities don't have accessible facilities. Women would have to travel hours to reach a hospital, so they simply don't go. They give birth at home, but now without even the traditional attendant because that's been made illegal or stigmatized. The best outcomes happen when you meet people where they are. If women in rural areas can't access hospitals, make sure they have skilled attendants nearby. If hospitals are accessible, make them welcoming and respectful. Don't just impose one model and assume it will work everywhere. In Latin America, many indigenous communities maintained their traditional birth practices even as hospitals became available. These practices often include specific positions, use of heat, herbal teas, and spiritual elements. Some hospitals in countries like Mexico have created culturally appropriate birthing rooms where indigenous women can give birth according to their traditions while still having medical backup available. These rooms might have ropes hanging from the ceiling for women to hold during labor, traditional birth stools, space for family members, and traditional midwives. This is what good healthcare looks like. Respecting cultural practices, incorporating them where possible, and having medical intervention available when needed but not forced when not needed. In Japan, birth has been highly medicalized, but there's also a tradition of gentle, quiet birth. Many Japanese hospitals emphasize creating a calm atmosphere. Some offer water birth. There's cultural value placed on the mother remaining composed and quiet during labor, which sounds restrictive but is seen as dignified and strong within that cultural context. Japan also has excellent postnatal care. New mothers often stay in a postpartum hotel for a week or two after birth, where they're cared for, taught infant care, and given time to recover before going home. This is covered by insurance or subsidized by the government. Contrast this with America, where you're often discharged from the hospital 24 to 48 hours after birth, sent home with a newborn, and expected to figure it out. No wonder American women struggle. In Scandinavia, there's strong midwifery care, generous parental leave, often a year or more, and comprehensive home visiting programs. A nurse or midwife comes to your home multiple times in the weeks after birth to check on mother and baby, answer questions, provide support. These countries understand that birth isn't just the moment of delivery. It's a process that extends through pregnancy and the postpartum period. Supporting women throughout that process improves outcomes for everyone. The Netherlands, as we've mentioned, has a unique system. Midwifery is primary care for low-risk pregnancies. Home birth is normal and supported. After birth, a maternity nurse comes to your home for a week, helping with the baby, doing light housework, making sure the mother rests. Dutch outcomes are excellent. Low maternal mortality, low infant mortality, high satisfaction rates, and it's not more expensive than highly interventionist systems. It's often cheaper because you're not doing unnecessary procedures. What the Netherlands figured out is that most pregnancies are normal, most births are normal, and normal doesn't need intensive medical intervention. Save the expertise and technology for when it's actually needed. Meanwhile, in countries with less developed healthcare infrastructure, birth outcomes depend heavily on access. In remote areas, women might have no access to skilled attendants, emergency care, or even clean water. Maternal and infant mortality remain tragically high. Organizations like Doctors Without Borders, Midwives for Haiti, and various UN initiatives work to improve access to skilled birth attendants, emergency obstetric care, and basic supplies. Progress has been made. Global maternal mortality has declined significantly in the past few decades. But there's still so much work to do. Women shouldn't die giving birth. Babies shouldn't die being born. We have the knowledge and technology to prevent most of these deaths. It's a matter of resources, infrastructure, and political will. One fascinating aspect of looking at birth globally is seeing how different cultures understand pain, risk, and the birth process itself. Some cultures see birth as a dangerous passage that requires spiritual protection. Others see it as a natural process that women's bodies are designed for. Some emphasize stoic endurance. Others encourage vocal expression. None of these approaches is inherently right or wrong. They're different cultural frameworks for understanding the same biological event. Problems arise when one culture's approach is imposed on another, when women aren't allowed to birth according to their own cultural values and preferences. The ideal system would be flexible enough to accommodate different approaches while ensuring safety and respect for all women. Now, let's bring this back to the present and talk about where we are today, right now, in 2026. Birth in the developed world today looks different than it did even 20 years ago. We have more technology, more knowledge, more options, and yet, many of the same problems persist. Interventions are still overused in many places. Cesarean rates remain high. Maternal mortality, especially for women of color, remains unacceptably high in countries like the US. But there's also more awareness, more advocacy, more women demanding better. The conversation has shifted from "doctor knows best" to "here are my options, help me make an informed decision." Doulas have become more common. These are trained support people who stay with you throughout labor, providing continuous physical and emotional support. Study after study shows that having a doula improves outcomes, reduces interventions, increases satisfaction. Yet doulas often aren't covered by insurance, so this proven intervention is only accessible to those who can pay out of pocket. That's a policy failure. Birth centers have emerged as a middle ground between home and hospital. These are designed for low-risk births, staffed by midwives, homey and comfortable, but with medical equipment available, and usually located near a hospital for easy transfer if needed. Birth center outcomes are excellent for appropriate candidates. Lower intervention rates, high satisfaction, good safety records. But again, access depends on geography and insurance coverage. The medicalization versus natural birth debate continues, though it's become less polarized. Most people now recognize that both extremes are problematic. Refusing all medical intervention can be dangerous. Insisting on maximum intervention is also problematic. The middle ground, using intervention when needed but not routinely, respecting the birthing person's choices, having skilled attendants who can recognize when something's wrong and respond appropriately, that's where good outcomes happen. One area where technology has genuinely helped is in monitoring high-risk pregnancies. Women with conditions like preeclampsia, gestational diabetes, placenta previa. These pregnancies need close monitoring and often medical intervention. Modern medicine saves lives in these situations. The problem was never medical intervention itself. The problem was applying interventions designed for high-risk situations to everyone, including low-risk people who didn't need them. Birth preferences and birth plans have become common. Women write out what they want, what they don't want, what's important to them. Some hospitals and providers embrace this. Others resist, seeing it as patients trying to dictate medical care. But here's the thing. Birth isn't just a medical event. It's also a profound personal experience. How someone gives birth matters to them. Their preferences matter, and unless there's a clear medical reason to override those preferences, they should be respected. This is true for pain management too. Some women want every pain relief option available. Some want to avoid medication if possible. Some want an epidural early. Some want to try without. All of these are valid choices. The judgment needs to stop. Women judging other women for their birth choices is counterproductive. The medical establishment judging women for their choices is worse. Pain medication doesn't make you weak. Going without doesn't make you superior. Having a cesarean doesn't mean you failed. These are all just different ways of giving birth, and as long as everyone survives and is treated with respect, the specifics don't matter. Social media has complicated things. On one hand, seeing diverse birth experiences normalized is helpful. On the other hand, there's a lot of judgment, misinformation, and pressure. Instagram births that look peaceful and beautiful can make people feel inadequate when their birth was messy and hard. Real birth is messy. It's unpredictable. It often doesn't go according to plan. Bodies do unexpected things. Complications arise. And that's okay. That's normal. The Instagram version isn't reality. Looking back through all of history, what have we learned? Women have always given birth. In every era, every culture, every circumstance. And women have always helped other women through it. The best outcomes happen when birthing people are supported, respected, informed, and surrounded by people who know what they're doing. That was true in ancient Egypt. It's true now. Intervention has its place. Medical knowledge saves lives, but intervention should be used judiciously, when needed, not routinely just because we can. Position matters. Upright positions with gravity helping are easier than lying flat. Thousands of years of women knew this. We forgot it for a couple centuries. We're remembering again. Support matters. Continuous support from someone who cares about you improves outcomes. This has been proven repeatedly. It's not optional. It's essential. Pain is real. Labor hurts. Managing that pain, whether through breathing techniques, medication, or support, is valid and important. The suffering is good for you crowd was always wrong. Experience matters. People who have attended hundreds of births know things that people who have read textbooks don't. Both kinds of knowledge are valuable, but experience shouldn't be dismissed. Culture matters. How people understand and approach birth is shaped by their cultural background. Imposing one culture's approach on everyone doesn't work. Flexibility and respect work better. Bodies are different. What works for one person might not work for another. Cookie-cutter protocols miss this. Individualized care is better. And finally, perhaps most importantly, the person giving birth matters. Their choices, their comfort, their dignity, their experience. Birth happens to them. They should have agency in how it happens. We've come a long way from ancient birth stools to modern hospitals. We've gained a lot. Medical interventions that save lives, pain management options, understanding of complications. But we've also lost things. Community support, respect for women's knowledge, patience with natural processes. The ideal modern birth would combine the best of both. Medical expertise available when needed. Support and respect always. Choices honored. Interventions used thoughtfully. The person giving birth at the center of their own experience. Some places are getting there. Many aren't. The work continues. As you drift off to sleep tonight, think about this long arc of history. Women giving birth in ancient Egypt, medieval Europe, Victorian hospitals, modern delivery rooms. Different eras, different methods, but the same fundamental experience. A person's body opening, a baby emerging, life continuing. It's happened billions of times. It'll happen billions more. The methods change. The technology evolves. The politics shift. But the basic reality remains. Birth is hard. Birth is powerful. And birth deserves respect. May we keep learning. May we keep improving. May we honor both the wisdom of the past and the possibilities of the future. May every person who gives birth be treated with dignity. May every baby be welcomed safely into the world, and may we never again decide that men who've never experienced childbirth know better than women who have. That's where we'll leave this story. The rain is starting to fall now, soft and steady. The fire is crackling nearby, warm and comforting. Let these sounds carry you deeper into rest. Birth will continue. Women will continue. Knowledge will continue growing. And you, dear listener, can sleep knowing that throughout all of history, despite everything, humans have persevered. We've given birth, raised children, passed down knowledge, and carried on. Sleep well, rest deeply. Let history and rain and fire hold you gently through the night. And now my voice fades away, like a candle going out, like daylight slipping into dusk. The story is told, the history is shared, and what remains is simply the sound of rain, gentle and constant, falling on leaves and earth and stone. The fire crackles softly, a companion through the dark hours, keeping you warm, keeping you safe. Let these sounds be your lullaby. Let them carry you through the night, and when morning comes, you'll wake refreshed, renewed, carrying with you this strange and fascinating journey through time. Good night.